Jonah.
Hey guys, well thanks very much. Thanks for the introduction. Thanks for having me here today. You know, it was very exciting for me when I found out that the ASDAH conference was in Boston. This is where I was born and raised. This is where my wife and I live and where we practice. But as I was preparing the presentation, I was thinking about, for a lot of you, you're not necessarily coming from right around the corner like we are. So I wanted to take a second to acknowledge everything that everybody here has gone through to be here, both in terms of whether it's travel or time or whatever it's taken for you to be here today. I just wanted to thank you for that. It also occurred to me that for those of you who had never been to Boston before, your very first introduction was probably something like this through your plane window as your plane was circling over the harbor and getting ready to land at Logan over there. So if we look all the way at the left side of the slide here, if we were to zoom way in there, what you would see is the hospital where I did my dietetic internship. Now, if you're sitting with any dietitians right now, during break time, I'm sure they'd be happy to tell you all about their internship and all the things that interns do. Everything from working in the transplant unit to chopping vegetables in the cafeteria kitchen. We do all sorts of things. One of the rotations that I had was in the bariatric surgery clinic, and there were two dietitians who worked there. Now, relative to each other, one of them was bigger and the other one was smaller. And because I shadowed both of them, I know that they were both excellent at their jobs. They both did pretty much the same thing, taught the same material, used the same approaches, but they weren't seen the same way. They weren't perceived the same way by the patients because of their size. So in reference to the larger dietitian, some patients would say things like, look how big she is. How can she possibly help me? Whereas in reference to the smaller dietitian, patients would say things like, look how small she is. How can she possibly know what it's like to be me? So for me, as an intern about to start my dietetic career, that raised all sorts of questions. I kind of looked myself up and down, and I was like, well, what am I supposed to look like then? And that question always stuck with me. And it planted the seed that's eventually grown into the talk that I'm giving today, which I've nicknamed Looking the Part: Patients' Size-Based Biases Towards Their Practitioners and How to Handle Them. So first, let's give ourselves a little bit of context here by acknowledging that patients carry all sorts of biases about their practitioners that aren't necessarily related to size. So let's give ourselves a little bit of context by taking a moment to look at some of those. So for example, there's a study done that looked at the clothing that physicians wear and the impact that that has on patients' trust and confidence in them. So we've got 4 different outfits here, going in starting in the upper left and going in clockwise order. We've got scrubs, formal business attire, white coat, and then casual dress. And what they found, the researchers found that by far, not even close, the white coat by far the most trust and confidence. Over 3/4 of the people found more trust and confidence in doctors wearing white coats. So much so that these people were saying they were more likely to talk about sensitive subjects like their sexual problems, their psychological problems, their social problems. Just put on a white coat, and that's apparently all it takes. The white coat was also found to be the preference of parents bringing their children to the emergency room. That is, unless their children were there for a surgical emergency, in which case they preferred scrub-wearing doctors, which suggested that perhaps on some level at least the clothing was indicative to the parents of perhaps either experience and or expertise. Now there's similar research out there showing that things like hairstyle, there's biases related to that, even whether or not the practitioner wears a name tag, there's bias associated with that. But of course, everything that we've looked at so far is readily modifiable to an extent. You know, we can change our clothing if we want, we can change our hair if we want, we can put on a name tag if we want. But of course, not all sources of patient bias are so easily changed. So let's look at some of those. There's a study done on orthodontists, and it looked at how parents select orthodontists for their children. And what they found was biases towards young females. That was the preference. And the reason for that, the subjects indicated, was because they saw young as being indicative of more up-to-date with modern techniques, and they saw female as more compassionate, more empathetic, and better at communication. So all of that spells good news for the orthodontist, like the one pictured here, who was nice enough to let me use her picture on the condition of anonymity, but probably not such great news for some of her peers who happen to be older and or male. So just like there's not a whole lot that we can easily do about our age or our gender, our size is largely out of our hands as well, as we all know. Now let's turn our attention to the subject at hand then and look at some of these patients' size-based biases. And there's 3 different studies that I want to go through with you. The first one was done at Yale, and they sought to answer the question, does physician weight affect patients' selection, trust, and willingness to follow medical advice? So what they did was they got 358 adults from the Yale School of Management database. So that's not people who have gone to the Yale School of Management. It's just a database that they maintain of people across the country. And what they did was they split these subjects up into 3 different groups, and they gave them surveys. And all the surveys were exactly the same except for one component. They changed the physical description of the doctor. So in survey number 1, they described the doctor as normal weight. In the second one, they described the doctor as overweight. And the third one, they described the doctor as obese. Now, just as a verbal footnote here, when I say those terms, I'm sensitive to the fact that a lot of us have feelings about those terms. I struggled what to do about that. Ultimately, I kind of felt like, well, like it or not, this is the language that every single researcher uses. So I felt like if I'm describing their research, I better use their language. And if that's anything that anybody wants to talk about, we can certainly revisit that at the Q&A. So back to here. So let's see what they found. What they found was, quote, respondents reported more mistrust of physicians who are overweight or obese, were less inclined to follow their medical advice, and were more likely to change providers if the physician was perceived to be overweight or obese compared to normal weight physicians who elicited significantly more favorable reactions. These weight biases remain present regardless of participants' own body weight. So in other words, what they found was that these subjects, the weight of the doctor meant so much to them that not only were they less likely to follow the medical advice of a doctor who was overweight, but they were more likely to switch to another provider. Anecdotally, we see examples of this as well. One of my colleagues who asked to remain anonymous and for her specific field to remain anonymous as well, told me one anecdote. She said, quote, I had a patient who was coming to see me to figure out if she wanted to be abstinent from substances. At the second session, she was crying and couldn't look at me. The patient said, I have to talk to you about something. Look at the size of you. How could you possibly help me? The second study I want to show you was done at Johns Hopkins, and this time things go in a little bit of a different direction. So this time, they sought to answer the question, does physician body mass index impact patient trust? So a little bit of a more narrow focus compared to the Yale study, and also a little bit more of a narrow focus in terms of the subject. So the N was greater here. They had 600 subjects, but they specifically selected non-pregnant, overweight, and obese patients compared to just a sort of cross-section. So these are patients across the United States. And what they did for these people is instead of using those verbal descriptors of normal, overweight, and obese, they tried to convey the same information by using photograms instead. And what they found was, quote, overweight and obese patients generally trust their primary care physicians, but they more strongly trust diet advice from overweight PCPs as compared to normal BMI PCPs. So let me say that again because that's a little bit different than what the Yale study found, right? So what they're saying here is that these patients, hey, they generally trust their doctors regardless, but they more strongly trusted the dietary advice if it was coming from an overweight doctor compared to a normal weight doctor. And what they found too is when they looked at other kinds of advice, such as exercise advice, they found the same thing. But in those cases, it wasn't significant, statistically significant, where in the case of diet advice, it was statistically significant. So that got the researchers thinking, and in their discussion section, they were hypothesizing as to why this might be. And what they thought might be going on is they were thinking that, well, if the patient and the practitioner are more or less the same size, perhaps that creates some sort of bond of trust. And maybe that's what led to this. Of course, that's something that would need follow-up study. That's just what they're thinking might be true. But anecdotally, we see examples of this sort of thing as well. One of my colleagues, a dietitian who asked that I not use her name, told me, quote, "I had a new patient and she refused my intern." So in other words, she had an intern following her, and the patient asked for the intern to please leave the room. And so when I sat down to do her session, she told me she was sorry that she asked the intern to leave, but she didn't want another skinny dietitian telling her she can't eat more than 1,200 calories and must record everything. She was relieved when she saw me. Let's go on to the third study. Now this time we're going to hop across the pond to the UK, and this one was done at the University of Gloucester. And they sought to answer the question, do the physical characteristics of sports dietitians influence athletes' perceptions of effectiveness? So this time what they did was they took 100 competitive athletes across the UK. And these were, they purposely wanted to make sure they weren't inadvertently selecting athletes who were just from sports where weight or size or appearance matters. You know, it's not like they took like 100 horse jockeys or something like that. These were athletes from like 17 different sports. And what they did in this case was they used a photo of a woman and then used a computer to manipulate that picture to make her bigger or smaller. And they changed her size to 4 different points to represent 4 different BMI points ranging from a low of 23 to a high of, I believe it was 38. They also superimposed different clothing on her, but I'm going to leave that aside because that's not really what we're here to focus on today. So just in terms of the weight, what they did was then they asked 2 questions. The first question to the athletes was, 1, of these 4 people, who do you most want to work with? And 2, who do you think is best at their job? So what they found was, quote, normal and pre-obese sports dietitians were rated and ranked significantly more positively than the class 1 and class 2 obese sports dietitians by the athletes. So in other words, the athletes said that not only did they prefer to work with the smaller dietitians, but they presumed the smaller dietitians were better at their job as well. And again, these weren't even real people. It was the same person who was just graphically manipulated. One of my colleagues, you're going to recognize this name, Flores. He's a dietitian out in California who's very active in social media, so a lot of you probably know his name. He was telling me, quote, more than anything, I've really noticed the looks more in the comments. I can see someone look at my stomach as I talk to them, and then back at my eyes. For some people, I can see how their body language changes in a negative way when they see what I look like. So, back to that question I asked myself as an intern, in terms of, well, what am I supposed to look like then? And quite candidly, the answer at this point really seems to be like, who knows? I mean, you know, we've seen research showing that some patients prefer us smaller, some patients prefer us bigger. Of course, some patients don't care. But here's the thing, you know, whether the majority of patients want us to be a certain size, or whether just the minority of patients want us to be a certain size, almost doesn't matter. Because what we've seen is that while these biases, yeah, they exist, they're inconsistent. They vary from person to person. So really, it comes down to the individual. When you're doing one-on-one work with somebody, and they come into your office for the first time, who knows what feelings or biases he or she is bringing into the office about your body. So if we were to make assumptions about the existence and the nature of their bias, then we're being biased ourselves. So if we want to be able to provide the best quality care that we can for our patients, we need to be able to set the stage, create an environment where their biases can be revealed, explored, and discussed. And one of the ways in which we can do that is to use motivational interviewing. So Dr. Glovsky, who's going to be up here in a minute, she's going to give you a much better rundown of what motivational interviewing is and how it works and its applications. I just want to take a moment and focus on specifically how it's going to come into play when it comes to these size-based biases. So there are two motivational interviewing terms that I want to differentiate between, resistance and discord. So resistance is sustained talk. It's arguments for the status quo, or arguments not to change. For example, let's say that a patient and a practitioner are having a discussion about the patient's smoking habits. The patient might say something like, smoking's so relaxing. I'd really hate to lose that. That's resistance. Discord, on the other hand, isn't an issue between changing or staying the same. Discord is an issue between the patient and the practitioner. It's a problem in their relationship. It's an issue between the two of them. So think about some of the anecdotes that we've seen up to this point. If someone walks into your office and they say, how can you possibly help me? Look at you. That's discord, right? So if something like that happens, first thing we want to remember is, remain neutral. It's human nature. We're probably going to feel defensive. We're going to feel like we're on the attack. But remember that in a professional environment, the focus is on trying to help the patient, not necessarily defending ourselves. So what we want to do instead is to use some motivational interviewing techniques, things like summaries, open-ended questions, affirmations, reflections, things like this to further the discussion. And what might happen eventually is that an educational opportunity might present itself. For example, maybe you'll get a chance to talk about some social norms that might be off base, such as the notion that we have to be a certain size or weight to be healthy. Now, during the course of these conversations, it's very tempting to use self-disclosure. Since we're already the subject, or since our bodies are already the subject of the discussion, it can be tempting to add more information about ourselves. And certainly, I know some practitioners who do that successfully and constructively. However, we want to be careful of that because oftentimes it can backfire. Instead of making discord better, it can actually make it worse, and it can widen the gap between the patient and the practitioner. So a general rule of thumb to keep in mind would be, if you're not sure self-disclosure is going to help, probably better to play it safe and not do it. Instead, just deflect whatever the patient said and use those other techniques that I mentioned to further the conversation and just see where it takes you. So I almost forgot I was about to summarize, and I had another couple slides. Silly me. That's what happens when you're nervous. The nature of my work is one-on-one counseling, so this is like 75 times the audience that I'm used to having. So some things that you could potentially find useful during the course of this discussion. It's hard for you to understand how it could be advising you when you think my appearance does not conform to some standard. If you had diabetes, would you only see a clinician who had diabetes? What is it like for you to be talking about these things with someone as large or as small as I am? What's worrying you about my size? What concerns you about my size? Tell me more about what my size means to you. Now, two things about these example quotes that I put up here. First of all, you got to tweak the wording so that it sounds like you. It's going to depend on the flow of the conversation up to that point with the patient. It's going to depend what kind of language the two of you are using. So you've got to make it your own. The other thing, too, is that the tone of voice, of course, matters as well. Right now, when I say it, it sounds a little bit artificial because we're here at a conference and I'm reading from a slide. But, of course, when you are one-on-one with your patient, your tone of voice is going to reflect your genuine sense of non-judgmental curiosity that, hey, you just want to learn more, you're just there to help, you want to better understand where they're coming from. So here's the slide that I thought I was getting to a second ago. So to summarize some key points that I hope you're going to take home from today. First of all, research confirms what we anecdotally already knew. Patients do often judge practitioners for their size. However, the nature of that bias varies from patient to patient. So therefore, while we have to be conscious of the likely existence of bias, we want to be careful about making assumptions of the nature of that bias, and still remember to treat each person as an individual. When size-based bias is encountered, explore it in a neutral, non-judgmental fashion using motivational interviewing techniques, with the end goal being to provide the best care that you possibly can. So I'm not going to be able to stick around very long today. I apologize that my wife and I our time here has been so limited. I had an operation a couple weeks ago, and there's only so much time I could spend out of bed. But if you have any follow-up questions after the panel is done today, feel free to shoot me an email. Jonah at SulmanNutrition.com, or if you want a copy of the slides or anything like that, feel free to reach out. I want to thank you again for the invitation to be here today, your time and attention, and everything that each one of you has gone through to be here today. I really appreciate it all. Thanks again.